And that is Dr. Chavez McGregor from the UT/MD Anderson Cancer Center, who will be presenting results from a phase 3 randomized placebo-controlled trial evaluating adjuvant endocrine therapy plus or minus 1 year of everolimus in patients with high-risk hormone receptor positive HER2-negative breast cancer, SWOG S1207.
On behalf of my co-authors, it is my pleasure to present today with you the results of SWOG 1207, a phase 3 randomized placebo-controlled trial evaluating the role of 1 year of adjuvant everolimus in combination to adjuvant endocrine therapy for patients with hormone receptor positive, HER2-negative, high-risk early-stage breast cancer. The PI3 kinase AKT pathway is involved in cell growth and tumor proliferation. It is known that dysregulation or abnormalities in this pathway are associated with resistance to endocrine therapy. The Bolero-2 trial demonstrated that everolimus, an mTOR inhibitor in combination with exemestane, improved progression-free survival compared to exemestane alone amongst patients with hormone receptor-positive, HER2-negative metastatic breast cancer. With this in mind, it was important to then evaluate whether everolimus in the adjuvant setting could improve the outcomes of patients with early-stage breast cancer. With this in mind, we designed S1207 in order to evaluate the role of everolimus in combination with endocrine therapy in high-risk early-stage breast cancer patients. Patients were eligible if they had histologically confirmed invasive hormone receptor positive or HER2 breast cancer according to ASCO-CAP guidelines. Patients needed to belong to one of 4 high-risk groups as they're shown in the slide. It is important to emphasize that all the patients in the study received either neoadjuvant or adjuvant chemotherapy. Patients were randomized 1-to-1 to receive physician's choice adjuvant endocrine therapy in combination with either everolimus or matched placebo for a duration of 1 year. This is the study schema, better illustrating the 4 high-risk groups. It is important to note that eligibility criteria were different if patients underwent surgery first or if they received neoadjuvant systemic chemotherapy as initial treatment modality. Patients receiving surgery first were eligible if they have no negative tumors and tumors that were 2 or greater centimeters. In addition, no negative patients needed to have recurrence score greater than 25 or mamma print high. Patients with 1 to 3 positive lymph nodes were eligible if they had either recurrence score greater than 25, mamma print high risk, or grade 3 tumors. All patients with 4 or more positive lymph nodes were eligible for the study, and all patients were required to have completed adjuvant chemotherapy prior to registration. If radiation therapy was indicated, that also needed to be completed prior to registration. For patients that received neoadjuvant chemotherapy as initial treatment modality, those that had residual disease of 1 or more lymph nodes in the surgical specimen were eligible. At the time of randomization, stratification occurred according to those 4 factor levels. Patients receive everolimus 10 milligrams daily or matched placebo, in addition of adjuvant endocrine therapy choice of the treating physician. The primary study of the design was invasive disease-free survival. Our study had 80% power to detect a hazard ratio of 0.75%, and we conducted 3 interim analyses at 40, 60, and 80% of the invasive disease-free survivals, and futility was also evaluated at those time points. Secondary endpoints included overall survival, safety, as well as pre-planned evaluation within the high-risk groups. We also plan to conduct exploratory analysis according to other known prognostic factors. After activation, the design of the study was modified to better reflect the risk group enrollment and also due to slow accrual. The sample size was changed from 3,500 to 1,900. This was also associated with a decreasing power to detect a hazard ratio of 0.75 that went from 90% to 80%. It is important to mention that no outcome information was used to change the design. The final analysis was planned when 219 invasive disease-free survival events occurred in the control arm or 3 years after last randomization. This final analysis was conducted when 211 invasive disease-free survival events occurred in the control arm. The study was activated in September 2013 and closed in May 2019 after 1,939 patients were randomized. 75 patients in the everolimus arm and 70 patients in the placebo arm were ineligible. Main reasons for ineligibility including registration outside of pre-specified protocol time windows or tumors that were either HER2 positive or HER2 equivocal. A total of 1,792 patients were included in the analysis, 896 in each arm. As of October 2022, median follow-up among alive patients was 55.2 months. In this table, we show the table characteristics of the patients. We recruited 11 males, and the median age of the participants in the study was 54 years old. Majority of patients were white, with 6% of the patients self-identifying as Black and 9% reporting Hispanic ethnicity. In the red box, we're highlighting the distribution according to risk group. Arms were well balanced, and as you can see, 40% of the patients received surgery up front and had 4 or more positive lymph nodes. Also, 40% of the patients in the entire trial received neoadjuvant chemotherapy up front and had 1 or more residual lymph nodes. According to the study, menopause was defined as previous history of bilateral oophorectomy or last menstrual period greater to 12 months without any history of hysterectomy. Based on this definition, 32% of the patients were premenopausal and 68% were postmenopausal. In this table, we show the treatment summary. 73% of the patients in the placebo arm and 48% of the patients in the everolimus arm completed 1 year of assigned therapy. Amongst patients in the placebo arm, 10% suspended treatment due to adverse events compared to 37% amongst patients in the everolimus arm. Progression or relapse was a reason for treatment discontinuation in 5% of the placebo arm and in 2% of the patients in the everolimus arm. In this graph, we show the primary results of the study. Primary endpoint was negative, and we did not observe any benefit of adjuvant everolimus to adjuvant endocrine therapy in 1207 with a hazard ratio of 0.94. In this forest plot, we show the invasive disease-free survival subgroup analysis. We did not observe any differences according to high-risk group category or according to endocrine therapy received initially according to treatment arm. We did, however, note that premenopausal patients treated with everolimus had improved invasive disease-free survival. This slide shows the overall survival analysis demonstrated no improvement in overall survival with the addition of adjuvant everolimus to adjuvant endocrine therapy. Similar to the invasive disease survival subgroup analysis, the overall survival subgroup analysis demonstrate no differences according to treatment arm based on high-risk group category or based on treatment assigned. We observed, however, that premenopausal patients treated with tamoxifen had an apparent improvement in overall survival. To better explore the effect of everolimus among premenopausal patients, we conducted exploratory analysis according to menopausal status. Among postmenopausal patients, the addition of everolimus was not associated with improvements in invasive disease-free survival. An analysis among the 571 premenopausal patients demonstrated statistically significant improvement in invasive disease-free survival among premenopausal patients with a hazard ratio of 0.64 and a p-value of 0.02. When we evaluated an interaction term between treatment arm and menopausal status, the p-value was statistically significant. In this slide, we show the exploratory analysis according to menopausal status for overall survival. There were no differences in overall survival between treatment arms among postmenopausal patients. Among premenopausal patients, however, those patients treated with everolimus had improvement in overall survival with a hazard ratio of 0.49 and a p-value of 0.01. When evaluating the interaction between treatment arm and menopausal status, we observed a statistically significant p-value. Safety was a very important endpoint on this study. In this table and corresponding figure, we show the most common grade 3 and 4 treatment-related adverse events. It's important to note that there were no grade 3 adverse events. Among patients treated with everolimus, we observed 35% rate of grade 3 and 4 toxicities compared to 7% of patients in the placebo arm. Amongst patients treated with everolimus, the most common grade 3 or 4 adverse events included mucositis at 7%, followed by lymphopenia, hypertriglyceridemia, hyperglycemia at 4%. In conclusion, the addition of 1 year of adjuvant everolimus to standard adjuvant endocrine therapy did not improve invasive disease-free survival or overall survival. In 1207, we observe a low completion rate and also an increased rate of adverse events according to treatment arm amongst patients treated with everolimus. Despite this, we did not see any new safety signals associated with the use of everolimus. In an exploratory analysis according to menopausal status, the addition of everolimus to adjuvant endocrine therapy improved the invasive disease-free survival and overall survival amongst premenopausal patients. This observation is thought-provoking and hypothesis-generating. We want to share with you that we're planning very interesting translational studies that will evaluate the potential of predictors of everolimus treatment, drug toxicity, and that hopefully will help clarify important issues related to endocrine therapy resistance. We want to acknowledge and thank all the patients that participate in the study, as well as their families and their caregivers. Also, thank you to the investigators and all their study teams across the nation for helping in the conduct of the study. I want to thank you all for your attention, and I'll be happy to take any questions.
Thank you, Dr. Chavez McGregor, for your excellent presentation. And we'll now open up for questions. Maybe microphone 5.
Ian Kropp at Yale. Very clear presentation and interesting result. Did you happen to look at completion rate of everolimus and adverse events by menopausal status?
We did look at completion rate. The completion rate amongst premenopausal patients was lower than amongst postmenopausal patients. However, a landmark analysis at 1 year according to treatment completion did not show any differences.
Microphone 3.
Hi, Cornelia Liedtke from Germany. I also wanted to follow up on Ian Kropp's question and ask if you think that the dosage that you provided was the right one. I mean, there's a discussion that maybe 5 milligram of everolimus would be okay. So what's your personal opinion on that?
I think that we clearly had issues with tolerance, clearly reflected by the high rate of adverse events and the high rate of discontinuation. As some of you might know, there's a similar adjuvant study conducted by the French group, and there was a modification of the design to actually start in that trial at a dose of 5 milligrams and then escalate if patients tolerate. I think in hindsight, we could have considered different alternatives, but we did start our patients in 10 milligrams. We have not done a deep analysis in the dose reductions and whether patients that receive even lower doses may have, seen any signal over there. Thank you.
I think we can do 2 more quick questions. So we'll do one at microphone 2 and then microphone 1.
Yeah, thank you. Bill Sykov from Rhode Island. Apropos of the other questions that have been raised regarding this sort of puzzling finding of benefit in the premenopausal subgroup and not in the postmenopausal subgroup, was any effort made to monitor whether patients in the premenopausal subgroup had continuation or cessation of menses during study treatment?
As you mentioned, we're clearly hearing a common theme about different outcomes among pre- and postmenopausal patients. The treatment of the patients in this study was allowed to change. So we haven't really evaluated whether changes in treatment or changes in menopausal status had anything to do with this. I should mention that all our patients receive chemotherapy. Therefore, there might not be necessarily that many questions about whether some groups or not had chemotherapy-induced amenorrhea. We also explored the role of ovarian suppression. About 30% of the patients received ovarian suppression in the premenopausal group, and we haven't seen any difference according to that.
Thank you.
And microphone 1.
Osborne, Houston. I wonder if you have any mutations, PIK3CA mutation status on any of the patients. The reason I ask is that mutation status in early breast cancer predicts for a better prognosis and a better response to tamoxifen in a variety of studies. And I'd be worried that inhibiting that pathway might actually be deleterious for that reason.
We do not have that information yet, but we're going to be looking at a number of translational studies. We did collect tumor tissue, healthy tissue, blood, and actually we collected tumor samples on recurrence. So we might be able to look at some of those interesting questions and points.
Thank you.
Thank you.
Thank you again.